Welcome everyone to part 3 of our first QA forum of 2022. I'm Dr. Michael Novick, the Director of Education and Associate Director of Quality Assurance for vRad. We've spent some time recently talking about search pattern and satisfaction of search misses. Today I wanted to discuss some other common pitfalls we face in diagnostic radiology. Here is our accreditation statement and the learning objectives for this lecture. And now let's dive into our first case. This is a 61-year-old man with a cold, numb right lower extremity. These are axial images from a CT angiogram. There are many of them, so it will take us quite a bit of time to get through them all. Remember, you can pause the lecture at any point to scrutinize a particular finding. In this case, there are many secondary findings. I'd like you to focus on the arterial system, specifically for the right lower extremity, but when you do see the finding there, at that point, you can switch to the left lower extremity for a secondary finding. Here's a coned down view of the right lower extremity. Let's review our findings. I'm sure you all noticed the absent flow in the right popliteal artery and the early venous filling in the left lower extremity. I gave you a heads up about the findings in the left lower extremity in this case, but given the patient's clinical history, it would be understandable if you had missed them prospectively. Just remember, in all cases, review all the images, both sides. You never know where you're going to find pertinent findings. So our findings here are a right popliteal artery occlusion and a left lower extremity AV fistula, or are they? You may have noticed that rather than the abrupt cutoff of contrast you normally see with an arterial occlusion, there was a more gradual dilution of contrast as we moved inferiorly. In this case, the technologist acquired a new set of images having seen that original finding. Here they are. So is the right popliteal artery in fact occluded? In fact, it is patent. So once again, another reminder to review every series of images the technologist submits for every study. We've talked about this in the past for PE studies where there are frequently thin cut series that will reveal pathology that was not as conspicuous on the thick cuts. Our next patient is a 23-year-old woman with elbow pain after a fall. This lateral radiograph demonstrates the pathology rather nicely. There is a comminuted fracture of the radial head. And a posterior elbow joint dislocation. Recall that we described the position of the proximal ulna relative to the distal humerus in cases of elbow joint dislocation. This is the post-reduction lateral radiograph. I think you can all appreciate that the fine bony detail is somewhat obscured by the overlying splint. We do, however, have enough information here to let the referring clinician know that this is a successful reduction. And we can even see a portion of the radial head fracture on this oblique view. I wanted to show this study because we all, myself included, have a tendency to turn off a bit when we see that a study is degraded either by motion or some other artifact. And in fact, there's lots we can tell from even these markedly limited studies. This one's not so marked. For example, there was a case a while ago of a cervical spine study done post-trauma where there was significant motion artifact. And you could see, despite the motion artifact, that there was evidence of hardware failure. So when we just shut off and say the study is limited or non-diagnostic or suboptimal, we sometimes miss important findings. So make sure you take a look at everything, even if the study is limited. Our next patient is a 30-year-old man who experienced trauma both 3 months ago and 1 month ago. Accident prone, I suppose. This is a lateral radiograph of the knee. Seemingly benign findings here, maybe a little bit of enthesopathy at the quadriceps insertion. This case is the stuff of nightmares for all of us. Look all the way at the superior margin of the image here. Can you see it? There is a subtle lucency in the mid to distal femoral diaphysis. My goodness, I think 9 out of 10 radiologists would miss this with the history of trauma. Just in case you were wondering if the other images would save you, here's the AP view, and it's just as subtle on this view. Not so subtle on the follow-up MRI. Here are axial fluid sensitive sequences, and while you can't see the mass, you can certainly see the reactive bone marrow edema and soft tissue swelling in the distal femur. This is another good teaching point because if you were seeing this study without the plain radiographs, all you can see here really is some periosteal reaction and bone marrow edema and soft tissue swelling, no actual lesion. Here's the sagittal fluid sensitive sequence. Again, lots of aggressive looking bone marrow edema and soft tissue swelling. Here are the coronal T1 weighted images. Again, lots of angry looking marrow signal. No mass though. Let's review our findings. As we said, lots of pronounced bone marrow edema. Periosteal edema and soft tissue swelling. Are we done? We're not done. Our savvy tech in this case did one more sequence hidden all the way at the end of the study. Lo and behold, we went a little bit higher up on the thigh, and there's our lesion. It's mildly expansile, centered in the medullary canal, and predominantly hyperintense on the fluid-sensitive sequences. So again, this is just the stuff of nightmares. You have a kid who comes in with pain after trauma, and the lesion is partially seen at the superior margin of the radiograph. Just so easy to miss something like this. And even once we went to the MRI, the tech initially didn't scan the area of concern, so you can see what a pitfall this case was. Okay, our next patient is a 29-year-old woman with shortness of breath here for rule-out PE. These are our axial images from a CT angiogram of the chest. Just a reminder again that these studies frequently come with multiple series, thin cuts, thick cuts, MIPS. Make sure to review everything in every case. You never know where the pathology is going to be most conspicuous. Here are the coronal images from the same study. A reminder again, you can always pause the video if you want to scrutinize a particular finding or area of concern. Let's take a look at the very subtle findings in this case. It's tough to tell without scrolling up and back, but this is in fact the pulmonary vein. I think very few of us would even mention this finding. There is frequently mixing artifact in the pulmonary veins, and pulmonary vein thrombosis is so rare in and of itself. However, there's a caveat in this case. There was a prior study, and here is the CT angiogram that was performed about a week prior. I think you'll agree that the finding is much more convincing on this study, but more importantly, it was reported as a pulmonary vein thrombus by the previous radiologist. So this case is a reminder, review the prior images, and just as importantly, review the prior reports. I think this finding is real and has improved on the current study, but whether you believe it or not, it was discussed by the prior radiologist, and you are therefore bound to discuss it on the current study, even if it is just to dismiss the finding as artifactual. Personally, I'm comfortable removing the question mark here. Certainly on the prior study, I think this is a real thrombus. And that frankly changes the diagnosis on our current study from no acute pathology to resolving left lower lobe pulmonary vein thrombosis. Again, if you think this is a red herring and this isn't real, it's still important to mention it on the current study and talk about what you think the findings on the prior and current study represent. Next up is a 59-year-old man with back and abdominal pain for 7 months. These are axial images from a non-contrast CT scan of the abdomen and pelvis. I speak more generally about the osseous structures on abdomen and pelvis scans, but in this case, with a history of back pain, I would scrutinize those a little bit more. By now, you've probably already seen the finding is not related to the lumbar spine. Here are the coronal images from the same patient. Let's briefly review our findings. There is a sizable infrarenal abdominal aortic aneurysm. More importantly, there is also conspicuous perivascular haziness. The The size of the aneurysm and the haziness raises concern for impending rupture, and when you couple that with the history of abdominal and back pain for 7 months, this becomes a real concern. When I called the referring physician about this case, he was in a panic because the patient did not seem to be taking it very seriously, and they were struggling to get him into the hospital for vascular surgery consultation, so I can certainly sympathize with that. Another reminder here, look at all the images. Don't be satisfied when you make the important finding. In this case, there are some additional things to note. There are large bilateral common iliac artery aneurysms and bilateral common femoral artery aneurysms. Certainly these are secondary findings, but the vascular surgeon will no doubt want to know about them. This is a nice reference article on the subject. I'd recommend perusing it at your leisure, as this is a hyper-emergent finding that we see not infrequently in our practice. Thanks for joining me. I'll see you very soon for part 4 of the first QA Forum of 2022.